DSA for helping us with this campaign and reaching out and helping spread the word for universal health care. I know a lot of you saw the marches yesterday. There were 4,000 people in Ann Arbor. I think also there were at least 4,000 in Detroit, and then 800,000 in DC. And it's so good to see the parents, teachers, communities getting behind students and standing up, speaking out about corruption and money in politics and effective gun reform. Our kids should not have to fear being shot in schools. So I think a lot of these movements intersect, like along with universal health care. It's also a lot about money in politics. So I was just going to go over a couple of reasons why I believe that we need universal health care. Even though I have a job that provides me health benefits, my partner, my family members don't have adequate health care. And my sister, she works like a lot of people, part-time job, like at a salon and house cleaning. And thankfully there are free clinics and low-income clinics, but the services are limited. Like she was told she has to wait at least 4 to 5 months for a toothache, which could be a sign of an infection, and if it gets too bad, to go to the ER.
That ain't right.
Right.
Oh, right.
And my dad has been in and out of various jobs. He's finishing out a second run of chemo and working as a cab driver just to make ends meet. And thankfully, he has a family that can assist him with basic living needs, and his church, which is helping him with his heating bill. But without those supports, he would probably be homeless right now and on the street. I also got a chance to talk to a man yesterday who said he can't make over a certain amount as a carpenter, or else he will lose his health benefits for his children. So we also have these people who are stuck in a place where they're trying to make enough to afford basic needs, but then if they make too much, they won't be able to get health benefits for their kids, and they can't afford to pay out of pocket for those. I also know a woman who was told by her insurance company that her chemo drug was not approved, but they would pay for a completely different chemo drug that her doctor did not prescribe. Her doctor had to argue with them, as well as her, on the phone with these insurance companies. Even then, she had to pay for a lot of it out of pocket. So from a nurse's standpoint, I'm seeing far too many cases where my patients with no money and no homes have simply waited too long to seek treatment. And these are people, they're people in their 50s and 60s, and they're dying from these preventable conditions. So, and that's way too young to be dying from, like they're ignoring that growth or that chest pain and just coming in too late when they're in a health crisis already. So not only my family, but my community and this whole nation is struggling in this multi-payer healthcare system. And most Americans can't afford a $400 emergency, while insurance and pharmaceutical companies continue to make record profits. So we pay the most in healthcare costs in the world, but have worse health outcomes than countries with universal health care, and we are already paying for and deserve a universal system that will give us the freedom to live healthy lives and have stronger workplaces, communities, and schools, regardless of how much money we have or don't have. And this is Laura. She's an awesome organizer with Michigan United, so she's just going to talk. She's going to be helping us with our canvassing training today, and she's going to say a few things about why she's here.
Hey everyone, how's it going?
Hello.
Great to be in a room with you today. Welcome Detroit DSA to Michigan United. My name's Laura DePalma. I am a campaign director here at Michigan United. I am so excited to be connecting with you in one of the great and many moments of the whirlwind, in what we call a movement moment. Like Sarah said, I'm in this room and I'm in this building because I'm very interested in working on an intersectional platform around racial and economic justice. This campaign is highlighting the ways in which healthcare is inaccessible, and it is an issue rooted in intersectionality, both around economics, race, gender, all of the above. And so I think it's really important to root different campaigns in a larger worldview, and I'm so excited that Medicare for All Michigan is here in the room today, so that we can continue building around these campaign issues and building a progressive agenda across the state of Michigan. I personally have been without health care because I work on campaigns and I have a pre-existing condition. So when a campaign ends and the candidate either wins or loses, and you're working in politics as usual, so when the campaign ends, your job ends, you don't have health insurance anymore. I've done that for like 10 years. I worked on Obama's campaign, I worked on a school board race in Los Angeles, I worked as a campaign manager for Stephanie Chang here in Detroit. I worked on a single issue environmental justice campaign in East Lansing at Michigan State University. And all of those jobs ended in the world of politics as usual. There was no movement building, there was no like sustained relationship building. It was like, okay, this is your campaign goal, boom, this is the end of the campaign, this is the end of your job, move on to the next one. Meaning every single time I switched jobs, I switched health insurance companies. Meaning, if I have a pre-existing condition, anything before the ACA completely doesn't work for me, although I know the ACA doesn't work for me completely either. So we're stuck in that tension of the world as it is and the world as we're trying to build, and I'm here with you all today because we're going to build the world that we need and that we deserve. So welcome. And so I did my piece, Laura De Palma. I go by she, her, hers. And we're going to start with AJ, and we're going to go around the room. What's your name, gender pronouns, and what brings you in the room today?
Cool. I'm AJ, he, him. This is my first time coming to like a real life event around DSA and stuff. Mostly just
awesome.
online before, but so.
Welcome, AJ.
I'm Margie Mitchell. I'm with Miss UCAN. I'm a she, he, her. A she, he, her. No, he. Never mind. But at any rate, I'm here because I've been working on this issue since 1990. And it's about time. And I'm so happy we now have young people really involved in the issue.
Yeah.
I'm Peter Landon, he, him. I'm here because I've gotten active in DSA in the last 6 months or so, and my understanding is Medicare for All is the national campaign that we're plugging into in various places, so I wanted to be here for the Detroit, whatever we're going to do. Unfortunately, I can only be here for about a couple hours, but I'm glad to be here.
That's great. We're glad you're here for those couple hours. Cool.
I'm Jake, he is him. I just started getting involved with Lansing DSA and they shouted out this event, and I wanted to get involved in Medicare for All work, so decided to be here.
Oh, great.
My name is Mike Espago, he, him, his. Likewise, like Peter said, this seems to be the national campaign that is getting a lot of attention right now, getting a lot of momentum, so it seems like the right time. So I'm here.
I'm Kyle, he, him. I work with a lot of contractors, and I just know a lot of people in their mid-20s who are kind of getting thrown into the, crazy healthcare world right now, and really inspired me to be part of the issue.
Awesome.
Hi everybody, my name is Eric Krausak. I go with he, him, his. I'm with Medicare for All Michigan. I'm going to be helping lead a portion of the training today. And as a restaurant worker, I don't have health care. None of my coworkers have health care. As a graduated student, I have a small house worth of debt sitting on me. And luckily, no pre-existing conditions other than, eye impairment. I haven't had new glasses in over 5 years. Haven't seen a doctor in over 10. So I know that, primary preventative care is such a huge part of what single payer is going to provide for everybody by being able to make sure we're not having to wait until we have a catastrophic incident before we have to go and try and clean up or fix the damage that way. So just being able to canvass with people, pressure our legislators in town halls, and have public education campaigns has been really empowering to see all these people come out in support of single payer. I'm going to be talking about some of the pushback that people usually give, and just what I hear the most of is Yeah, I agree, but that's not possible, so we'll be speaking of that, so. Good to be here with you guys today.
Sean O'Donoghue, he and him pronouns. I'm here with Detroit DSA, and I've been pretty fortunate for most of my life to be healthy and recently have health insurance, but I've had a lot of people close to me who haven't and who have gone bankrupt to trying to treat preventable conditions, and I don't want anyone to have to go through that, and I would like to help convince other people who might not see it the same way that single payer is the way to prevent that from happening.
Right.
I'm Sean Cristofori. I'm from Waterford, Michigan. I'm with the Detroit DSA. I joined, I think, back in October, September. I really want to be part of today's training because I've never been part of, say, political organizing or political, I don't know, anything that, like I've never been part of a campaign, so I really would like to learn like how to do, I guess, politics like that.
Oh, great.
Yeah.
I'm Roseanne Freed, she, her, hers. I spent my entire adult life swinging back and forth between healthy and not healthy, and I know for me, it's really dictated how I've made decisions in my life in terms of my career and my choices. And it's limited my choices because I knew I would have to stick to certain jobs and couldn't leave them because of the healthcare they provided.
Right.
So that's a personal thing, but in general, I find that the idea of universal healthcare is just part of a whole idea of a culture being aware of how everyone's condition affects everyone else in terms of public health. And people are so unaware of the public health issues surrounding not having health care for everyone. And I feel like that's something I can help to work on educating people on that, because I feel like that's just missing from the discourse.
Yeah,
some
that's true.
I'm Rick Haberman, he, him. I'm with Detroit DSA, and the reason I'm interested mostly in our healthcare campaign is I lost my dad to brain cancer in 2017, and in a way he was very lucky because they had gold-plated healthcare, and so the road he traveled I think was as comfortable and palatable as it possibly could be under our current system. At the same time, my wife and I have been kind of rowing through the vicissitudes of the ACA until very recently, and that's been difficult. We've had to alter various things about our lives and have to have consider certain things that we never did before, because all of a sudden healthcare costs, really big healthcare costs, were a concern. So that's why I'm here.
Well done.
I'm Aaron. Big reason I'm here is just seeing community people I know that are growing through this. A friend of mine, there was a misdiagnosis, and then they discovered after the untreated diagnosis that she actually had brain cancer. So it's fighting through that, and she's in her mid-20s, and just that it took a year or two to get one diagnosis that led into this. Or I have a coworker whose 9-year-old son had jaw cancer, and the health insurance refused to pay anything but chemo for it,
Wow.
and he wasn't about to inflict chemo on his 9-year-old son, and it just seeing example after example just piling up, and it's just so frustrating and infuriating. Something has to change.
Right.
So.
I'm Tyler, he, him, and I'm just here to learn more about it.
Cool.
I'm Zach, and Zach Angel. I'm not affiliated with anyone, and I'm here because I'm really done with paying or having my family and I pay thousands of dollars for health insurance, and then still have thousands of dollars worth of medical bills. So.
Amen.
Exactly. All right, Eli, you want to take it away? Okay.
Thank you, Laura and Sarah. So welcome everybody.
Okay, so my name is Eli Rubin. I go by he, him, his. I'm a volunteer organizer with Michigan United and Michigan Medicare for All Michigan. And we've worked really closely with Huron Valley DSA and Southwest Michigan DSA, and so we have a really close working relationship. I'm just going to say a few things about myself why I'm in this fight. Okay, and then I'm going to give an overview of our campaign, which you're all now officially part of. So I've actually been pretty lucky with healthcare in that I have a pretty good employer plan, and I haven't had any serious health problems. In fact, I've never broken a bone or had stitches or had any serious illness. Even with that, my family pays $10,000 a year for our portion of our healthcare premiums, and my employer pays another $12,000 or $13,000. And then our co-pays are such that we avoid going to the doctor anyway, unless it's something absolutely necessary for kids, basically, because it just eats up our budget. So that's one thing. But for me, this fight is bigger. I got involved with, I was kind of like where Sean is now. I was about 14 months ago, right? I mean, I voted, right? And sometimes I'd send some money to a candidate, usually like the Democratic Party, or I'd send some money to some very recognizable, the ACLU or something like that. And then of course November 9th happened and Trump was elected. And I had some experience working with the Clinton campaign and saw how they were doing things and thought, this is awful, how this is run. It's so cynical. It's what we call transactional. It's just sort of, we pay people to go out, you knock on doors, when your time's up, you go home. There's no feeling, there's nothing about the actual needs of the people involved. And it occurred to me that all my life I've been expecting, I think Obama reinforced this, probably some of you feel the same way, I'm just kind of expecting that the Democrats would figure it out. Obama will take care of it. And then he'll just hand it off to Hillary and she'll take care of it. I mean, I voted for Bernie, but I figured Hillary would just take care of it. And hey, welcome. And it really hit me that nobody is coming to save us. Nobody is coming to help. Writing a check to the Democratic Party and expecting that they'll win and that's all that matters is part of what's wrong with this whole picture, this whole system. So how does one get involved? And of course there's lots of avenues, DSA is one of them. But I found that in Michigan United there's a sort of a whole theory and a practice that we'll talk a little bit about, and we're also going to shout out a whole bunch of trainings that are coming up like this one over the next 2 months that are about every aspect of organizing and activism. It's really about self-empowerment. Like Eric said, since he and I have been working with Michigan United on these campaigns, it sure as hell beats getting angry at Facebook. To get out there in the streets, to get out here and do this stuff. And neither of us are went to organizing school. Laura has an MA in social work and organizing, but for the most of us, none of us, are uniquely educated or prepared for this. We just came to some Michigan United trainings and got involved, and everybody else can do the same thing too, and then get more people involved. So for me, that's why I'm here. This is about fighting against a corrupt system, a neoliberal, capitalist system that corrupts our politics, that commodifies everything around us, including our very bodies, including the life in ourselves, is something to be profited or lost from. So that's why I'm here. And I want to just talk about our goal kind of here, and you'll see how your goals kind of intersect with our goals, and that's really the basis of us working together. Stand out of the way here so you can see. So we want to pass single-payer healthcare. We want that passed in Michigan or in Washington, whichever, it doesn't matter. Obviously it's preferable in Washington, but we know that a lot of things happen in the states first. Women's suffrage, labor laws, gay marriage. And we believe that both by working for this, and then when we get it, because we will get it, it will transform our politics. So it won't be that transactional, cynical, old style of doing things like I experienced on the Clinton campaign. Like if you've ever been to a Michigan Democratic Party meeting, you've probably experienced yourself, okay? And then of course, as Roseanne was saying, we will have a much more humane society when we have single payer. It'll be intersectional. The inequalities of our health system fall the hardest on women. They fall the hardest on people of color. They fall the hardest on working class people. And even middle class people. And so you strike a blow for economic justice, for racial justice, for gender justice, and frankly for trans rights and all kinds of other marginalized folks with this one fell swoop. It's that much at a crossroads of everything. So our strategy is we are a coalition of groups across the state. We've worked with Michigan, and for example, Michigan for Revolution, Our Revolution, Michigan, DSA, Indivisible, unions, and just lots of individual groups that don't even have a formal name. And we are leading an awareness, education awareness, and a pressure campaign. So we are beginning with education, kind of like what we're doing now, what we've done some in the past, what some folks like Eric and Sarah were doing just yesterday in Ann Arbor, to build capacity or base. And we'll talk in more detail later about this, but that capacity or that base, that those numbers of people will sway decision makers. And as we sway decision makers, we pick up more followers and so on. And we call this the prairie fire, meaning that we are trying to set in motion a movement that doesn't necessarily have one headquarters, one office, one controlling body. We see ourselves at Medicare for All Michigan, which is really an outgrowth of Michigan United, as sort of coordinating, doing these trainings. We've got materials for you guys to use, although DSA has its own materials too. Coordinating groups, putting people in touch with each other, connecting people. So it's decentralized, and most of all, we are looking for you guys to eventually become leaders in your own right, to become the people who can hold versions of this training and get more people involved, and then they become trainers and so on and so forth. And so we're just sort of coordinating it loosely. And this is not as, I think there's some one or two people in here who are not specifically part of DSA. We're going to talk at the very end of today about canvassing plans. If you are welcome to tag along with Detroit DSA since it's such an overwhelming presence here. But if you live really far away or something like that, you can also, we will kind of get you in touch with other people in your area. Right? We have a big list of people, and sometimes people are kind of spread out. There's people in like Livonia, people in Brighton or whatever. So just to talk a little bit about more what we mean by education and awareness. We're going to be talking about town halls, and we're going to be doing canvassing. We've also done tabling, for example. That's probably something you guys are familiar with. That's where you put a table at an event and you put your information out there. And for DSA, of course, you guys have your own materials, a lot of times your own stuff. But you can double up with Medicare for All Michigan to really put an emphasis on that. When we talk about canvassing, we can do canvassing in places such as, this is some of our efforts at organizing farmers at the farmers market and also customers, because farmers are uniquely screwed by our healthcare system actually, and that's where everybody gets their food from, and nobody thinks about how badly they suffer. So this is, see Eric and Sarah and I and some other folks organizing, and then you talk to folks, you talk to farmers, you talk to people, and then talk to 60, 70, 100 people, and you get 12 or 13 or 14 of them in a room. This is at the Argus Farm Stop. In the basement of the Argus Farm Stop is this fresh farm store in Ann Arbor. This is Yusuf Rabi, the representative from Ann Arbor, who we'll be talking a little bit more about in a second. He is the one writing the legislation for a single payer bill in Michigan. So, and then we'll go over town halls later in the training, but this is a town hall that we had with state senate candidates in Ann Arbor a few months ago. Swaying decision makers can take many forms, and one of those is town halls. We'll talk about that later, but visiting offices is something that we've been doing. We've taken teams to Gary Peters' office, to Debbie Stabenow's office. We've also organized teams to visit Stabenow's office in Grand Rapids and coming up in Lansing. So we're gonna want people for that. And these are really, really enlightening because usually if it's a senator, they won't meet with you first. If it's something controversial, as you guys know, Senator Stabenow and Peters have not signed on to Medicare for All, Senator Bernie Sanders' bill. And the reasons that they've given, you know, are oftentimes shifting and kind of hollow and transparent. And of course, you can look up on opensecrets.org that Debbie Stabenow's taken, I think is $60,000 from Blue Cross Blue Shield, and then from other health organizations, more tens of thousands of dollars. But having these conversations are important because the main office in Detroit, but also the offices in Lansing, Grand Rapids, Saginaw, Traverse, and so on, they file reports, and those reports get, you know, summarized into an overall report, and then it gets handed to the senator. And the more and more this keeps coming up, the more and more both senators have to keep responding to this. Every time they change their logic a little bit, they're running out of excuses very quickly. It also gives us an opening to keep the conversation going, to get that conversation inside of their office. A lot of times, the staffers will do the good cop, bad cop routine. We've seen that a lot. Well, they'll say, well, I'm all in favor of it. And I just have to, you know, convince my colleagues. And even if that's BS, it's still a conversation that's at least happening in their offices. Because of course, what we're up against is that the health insurance industry has millions of dollars to spend on lobbyists. And one of the things that we've learned in our organizing work is that actually politicians are quite accessible, much more than you'd think, especially state politicians. In fact, they crave that contact with you. They want to be contacted with you. They want you to invite them to your meetings. They want you to come and see them. We had one state rep from Ypsilanti say, at one of our events, say, I get lonely up in Lansing. The only people who come knock on my door are lobbyists. So that's all anybody hears from, is lobbyists. You know, y'all can come up and talk to me anytime. I would love it, but I only hear one side of the story, right? And so again, that's kind of the point of this, and we'll be doing a lot more of this. Also, we get a chance to read in between the lines. And some of the things that we've picked up are that, you know, Stabenow and Peters, they go with whatever way the wind is blowing. And they are not risk takers. They're centrists, and they aren't going to come out for something unless they feel the ground is really well prepared. And they've essentially said, you guys go out and educate our electorate. You know, get unions on board, get churches on board, get, you know, all the sort of pillars of our coalition on board, and then we'll change our mind and come out in favor of it. Okay? Something that Michigan has done a lot is having breakfasts with legislators where you actually invite them to coffee and bagels, and that works really well. We have every Monday, we have people call senators and state reps on healthcare, on single payer. We've done postcard parties, and then we've done direct actions. And we're not going to talk a lot about direct actions today. The focus is more on canvassing in town halls. We will be having direct action trainings coming up, and we'll talk a little bit about some direct actions. But in general, we want to use the gamut of techniques that are available to us as activists to change what's called the Overton window. Has anybody heard of this term, the Overton window, before? Yeah, Jake, what's the...
It's kind of like the center of, I guess, discourse in the current politics and where it's framed and how, you know, there's a left and a right, but maybe the center changes to more right, it has in our country, or more left. Right. So, and then now you see on this this area of, okay, like, left and right now means no healthcare for anybody or multi-payer or something, rather than single payer or the opposite.
Yeah, is that what, somebody else had their hand up. Is that what you were gonna say?
More or less.
Yeah, so this is this term for what's considered acceptable discourse. Basically, it's that moment in the like war room, campaign headquarters when a candidate says, "Why don't I just come out and say this?" And they're paid political consultants, with polysaccharides from Georgetown or whatever, say like, "No, you can't say that. Our focus group testing shows you can't say that because people haven't already heard it." And we have two really good examples, one good and one really bad, of how you can change that window from this last election. I mean, most Republican strategists would have said, you cannot come out and, with this like almost wide open white nationalist talk about immigrants being rapists and criminals. You can't say that. That's political suicide. And, Donald Trump, not listening to anybody ever, just kind of went ahead and said it and found that by saying it, he opened up that window. And now everybody's talking about it. Same thing with Bernie Sanders. In 2009, you'll hear a lot, and you'll hear a lot more as we go on with this campaign of Democrats who were around then, who will apologize for Barack Obama, will apologize for Schumer and Pelosi, saying, we couldn't have talked about single payer in 2009. The votes weren't there, the support wasn't there, but of course, they weren't talking about it either. So they wouldn't know if the support was there. And you'll hear that again and again and again. What we're trying to do is get the candidates talking about it again and again. Some of you have already done that. Leah did a great job bird dogging Senator Stabenow, and that's something we're gonna talk about doing again. There's an event coming up again where that's gonna be possible, where you get up and as annoyed as she gets, as ticked off as she gets, she has to keep talking about single payer. Until everybody knows what it is. And then base building is what we do. You guys have a good base already. It's in this room, but you can get even bigger. There's a lot of people out there who care about this. So we just want to talk a little bit about the status of the MyCare bill, just to kind of update you all. MyCare is what Yousef Rabhi is calling his single payer bill. He announced it at a very large rally that we held in Lansing last summer at the end of July as part of the nationwide day of action. We had about 350, 400 people come, and we went inside the state capitol, and Robbie got up and announced that he was going to be working on this. This is an incredibly ambitious legislator. Once he's done passing single payer, he's going to move on to free college tuition, and then what's called universal family care, which is another campaign of Michigan United's. The legislation, as you can imagine, took longer to write than they were anticipating, so it hasn't been introduced yet. But the latest we've heard is that sometime in April it will be introduced, and to the degree possible, there's some talk back and forth between Robbie and the Abdul campaign, who's also planning on releasing their single-payer healthcare proposition in early April. So, but he is coming to one of the events you have, one of the film screenings that there's a flyer for that Michigan is putting on in May. He's coming to talk about that. And I know that Leah and Rick and others have talked to us about putting on a town hall with him here in Detroit, maybe later in April, and that's also something where he'll talk about that. And so, if you have questions, I know some of what's in the bill, and we can talk a little bit more about that. And we are moving in the direction of forming ourselves as our own 501c4 organization, so that we'll just raise funds directly. We're not quite there yet, but hopefully in the next week or two. And then we can discuss, like, you guys have your own sort of funding streams, but for those people who want to work with us, we can kind of discuss how we work that out. And we have a website, MedicareForAllMichigan.org. This is again a resource for you. It's a way, when you guys go out and do stuff, we want pictures of it so we can upload them and show them to everybody.
So, are there any questions thus far about kind of who we are and what we're doing?
I just think it's important to highlight that march at the Capitol last summer was like just slightly over a month after we formed, and to see the support that was there was really groundbreaking. And as far as I know, people didn't know. Like, say, Yusuf, would you please introduce a single payer bill? He just sort of took it on himself to seize that moment and announce it to everyone. So there is a political will that's forming around this, even within elected officials.
Yep. Yeah, and again, like, you know, I can't tell you how many times I've been told that the gun lobby is undefeatable, they're invincible, we'll never get gun control in this country, Americans love their guns. I think you saw yesterday that there is untapped potential out there. It needs a catalyst, it needs people to organize it. So, and you know, the health insurance industry is not any more powerful than the gun lobby. Okay, so we're gonna turn it over to Sarah and Margie, and we're gonna get into now the real like nitty-gritty sort of top 10 talking points that we use, sort of the best arguments for single payer, and that you can follow along with in your packet. So thanks, Sarah.
Okay. So I could go through, and then if you have anything to add, Margie, just let me know.
We're testing.
Yeah. Okay.
Just use the arrows to go.
Oh, thanks. And so probably already, everyone already knows what universal health care is. It just means everyone's covered. Single payer means public funding, or one funder for all health care. Basically, it'll be funded through our tax money. And so I'm just going to go over 10 key advantages to why we would want to switch to a universal system from our current multi-payer kind of for-profit healthcare system. And like Eli was saying, we believe it's a valuable tool in solving our healthcare crisis, the inequalities, the costs, and the poor health outcomes that Americans face in this country compared to those countries with universal health care. The right to health care, we believe, is the right to life, liberty, and the pursuit of happiness. Health is not a commodity. It should not be bought and sold for profit. And most Americans believe the government has a responsibility now in the polls to ensure everyone has health care as one of the world's richest countries. And then fighting for a universal healthcare system, we're trying to fight for no more out-of-pocket costs, which only serve as a barrier to care for poor and working-class families. Working families of four now average over $25,000 a year in healthcare costs in 2016, and this has tripled in 15 years from 2001 when it was about $8,000. And employers paid an average of almost $15,000 a year per family of four, while employees paid an average of $11,000. And for most people, that's pretty unsustainable. The taxes needed to fund an expanded and improved Medicare for All program would be less than what 95% of Americans currently pay for healthcare costs. So it'd be worth switching over. Oops, sorry.
You can just use the right arrows there too.
Oh, okay. And when you're broken, when you're struggling to pay for basic needs, you're more likely to think away that chest pain or ignore that growth. Poverty means you can't afford co-pays, deductibles, and premiums. In our healthcare system, costs get in between your right to preventative and life-saving treatments and medications. I saw some people were being charged over $400 for an insulin vial that is supposed to only last a month. So for someone without insurance, I see people like rationing on their insulin and not, or going without, and then they end up in a diabetic coma. Or people like with asthma going without albuterol, which is vital in opening up your lungs. Like if your lungs are closing up. And also, like, I think a lot of us heard about the EpiPen, which the price went up 400% when Chairman Robert Corey raised the price. And this chairman made over $97 million in 2016. So we see where all that profit is and money is going. It's just going to like a small percentage of people. Everyone in and nobody out means more bargaining power in pharmaceuticals, medical supplies, and services. And our taxpayer money already pays for 2/3 of all healthcare costs in our country. And we're already spending enough money to take care of us all. Like Sanders' Medicare for All bill would cost, they say, about $1.4 trillion, and we're already paying $3.2 trillion in 2016 total for healthcare costs. So we would be paying less under a single payer system. Oh, no, I went over. Oh, sorry. Is it on a video? Oh.
Technical difficulties.
Yeah, I'm sorry.
Is it not working?
Oh, there you go. It's good now.
You just want to go to this one?
Yep.
Okay. Yeah, just use the arrows.
Okay. And with Medicare for All, we would have free choice of providers. We would still have private hospitals, private clinics, and private providers because some people argue that switching to, they don't want the government to take over our health care, but we would still have access to all the private providers that we do now. We just wouldn't be restricted to in-network providers. And yeah, so every provider for all medically necessary services would be in-network. And this is including also dental and vision, which right now a lot of people need a separate plan if they have health insurance to even cover those necessary services.
Sarah, let's make sure that people understand the difference between a government program that brings the financing in and the regulation in, but they do not, the doctors do not work for the government. The hospitals are not paid directly, by the government. So in England, all of the healthcare system reports to the government. Here, the financing goes out, and then, there is competition among all of the providers and that sort of thing. So it is not totally socialist. England has the only socialist healthcare system in the world. Many more of the countries have things that kind of combine. Some of them even work with health insurances, but they are highly regulated by the central government in what they can do and that they can't do and how much profit they can make. Just want to make sure everybody kind of understands that, because that's one of the things you hear, this is socialism.
Yeah, so it'd be like a national health insurance, basically, a way of seeing it. And private health insurance providing duplicate health coverage services under the Medicare for All bill would be prohibited, but this would ultimately save us $400 to $500 billion a year wasted due to profits taken by insurance companies and hospitals. Also, the money they use in advertisements and administrative costs. So we would no longer need all that administration staff arguing with insurance companies for approval of some type of treatment or service. And then moving to a single payer system would also give us more freedom from job lock when someone wants to leave a job but cannot risk being without the benefits of their company or organization. I know Roseanne was talking a little bit about that in her life. A single-payer healthcare system would be a major boost to entrepreneurship, new small businesses, and this would give us more worker flexibility and mobility. Studies show that 15 to 20% would seek other opportunities than their current job if they didn't have to worry about losing their health benefits. And we also believe that Medicare for All would be great for unions because unions would no longer need to negotiate healthcare benefits like they do year after year. They can get back to negotiating wages, pensions, and working conditions and focus on these, which are much needed in our current economic system. And HR 676, which is the expanded and improved Medicare for All bill in the House, has been endorsed by 633 labor unions. So some of the staffers at Stavenow's office has said that we need to get the unions on board as one of their, but they're already on board, so that's a good point to know.
What we have to do is get them telling her that they're
Right.
on board.
Yeah.
Do you get, just a question, do you know in particular which unions are biggest in Stabenhouse here? It's gotta be the UAW, obviously.
Yeah, I think the UAW.
Actually, most of them are. Even the teachers' unions have been more and more on board on it, and the retiree. I spoke to retiree teacher union just this past week. They're totally on board on all of that. So I think we underestimate the number of unions that are, the people.
Let me just clarify the question. I think maybe he was asking which union Stabenow leans on the most for like that she listens to.
I think it's UAW.
And they're against.
Well,
UAW
so
has
they
been
are
supportive
their
of single
national,
Yeah.
their national body voted just recently to endorse Medicare for All. But in my conversations with a lot of the people in sort of the Michigan Democratic Party who are very close to the UAW, I think there's a lot of hesitation. They still don't trust it. There's certain ways in which I feel like UAW is more conservative right here in Michigan than it is nationally. Now, I could be reading that incorrectly, but I think that that's one of the next steps.
I think
what we need to do
yes,
is to talk to them here in Michigan.
The issue for the unions is that many of them have very fine benefits. And they don't understand if they will be losing or not losing. And that's our job, to help them to understand that they shouldn't be losing, they should be gaining.
Right.
And so that's the thing that, they've always considered their things Cadillac, especially in the UAW, and they are. But, and certainly some of the teachers' unions and have been able to negotiate excellent health care. But you look at what they're getting, and it's in these. So, and the ease of use and everything, many of them are very frustrated in accessing and trying to get it from whatever insurance company is running theirs. The VIVA has worked pretty well for the unions, but it isn't an issue of we love the VIVA. We want healthcare that is the same or better than what we have. That's the issue, and we shouldn't get sidetracked by people trying to tell us it's something else. David, would you agree with that?
Yes, absolutely. The issues are.
He's a doctor. Actually, a neurologist.
The UAW has supported single payer going back to the 90s. That isn't the issue. The problem is what resources will they put behind it? And the reason that they don't put major resources behind it is because they already have healthcare through their negotiated contracts. What we have to point out to them is that this is constantly being chipped away at in negotiations. And if they take the long view, they really want to push for single payer so that that's taken off the bargaining table as an issue and they can talk about wages and working conditions. So that's the first thing. The second thing is that it's not so much that they're conservative, it's that they have other issues that they're working on. They feel that healthcare they're taken care of. And again, there are two different models of unionism, and one is social unionism where you're looking at the general welfare, and the other is business unionism where you look at basically serving your clients, which are your union members. And we want to reinforce or try to push a social unionism perspective. That's what I would add.
I would just, one thing that I'm not advised, but as a member of the UAW, there's just, when talking to them, there's some issues right now. There's a lot of corruption and there are actually multiple higher up members of the UAW being investigated by the FBI for various issues. So it's just something to keep in mind when talking to them. literally don't know if they'll still, how much longer they'll be in charge. So just something to keep in mind, that if you're talking to a couple individuals, or if you're trying to talk to as a whole, if there's a big, you know, upheaval within the leadership, which there's some movings here and there for, that it might not be there, who knows, a year from now, a couple years from now. So just a kind of heads up. I'm sorry.
Oh no, that's okay. Does anyone else have anything to say, like in regard to the unions? Yeah.
Well, just to follow up on David with social unionism, I mean, one of our dilemmas is you know, the private sector unions, including the UAW, continue to shrink. And they know that and we know that, and we sort of have to get across to them that if they want to continue to be relevant, or if we're going to rebuild the union movement in this country, it's got to have more of a sense of we're making this fight for our neighbors, for our relatives, and that's how the UAW was built in the 30s. You know, it was not a sort of single interest, or we're taking care of our own kind of thing, but it was for everybody, and we need to get back to that.
Right. Yeah.
I think you guys should tack on there that it's good for contractors and kind of freelance workers as well.
Yes, and people who own their own businesses that don't have to worry about where their health care is coming from.
Yeah, I mean, this is something that the farmers were telling us when we were organizing it, is that
Yeah.
they're almost all married to somebody else who has a job at Ford or the University of Michigan or something, so that they, otherwise there's no way. With doing dangerous work like farming and especially contracting, that you can go for very long without having any health care, and if you're gonna be paying $20,000 a year out of pocket, for a plan, I mean, for some contractors maybe, but for most farmers, no way can they afford that. Then on top of it, you have the problem of your employees, which I'm sure you can speak to, which is that, you don't get people sticking around for very long. People wanna get a job with benefits for themselves. If you can't pay them, you're constantly retraining people. You can never, keep them around, or can't keep good people around, so.
It's worth including that contracting and construction work is like the most dangerous, most lethal job in this country.
yeah.
You get crushed in trenches and by falling walls.
Fall
and
off roofs.
Debris all the time, so.
Well, when you say contractors, you're meaning independent folks doing tech work and everything else, right?
Yeah, or construction workers and
Yeah.
skilled trade
Just
laborers.
that we're all, or like Uber drivers are now independent contractors.
Right.
And it's,
Right.
And we have to remember to really work on this idea that the unions were founded on common good and community, taking care of each other. We have lost that in America. We somehow morphed into something where me first, I take care of me and my family, and I don't want to pay for you. And I think that we need to also have messages that bring us back, because healthcare for all is a large part of that. If we don't win that battle, we lose a lot. And the same thing for schools and everything else. I want my school good, but I don't want to pay for yours. And if we're ever going to do inequity, it always is a reallocation of some resources to try to bring people up. Rich people will never have any problem getting their needs met, but at what expense?
But we'll have a stronger workforce if we cover everybody, and a stronger population and country as a whole. So I feel like that could get some people on board if we focus on that too. Okay, I'll move on to the next. And this is what we were talking about that a little bit. Like switching to a Medicare for all would be beneficial for employers, because healthier people are more productive economically. And productivity losses linked to absenteeism cost employers an average of $225.8 billion annually in the U.S. So focus on prevention and get health will cut these costs. And also over 60% of bankruptcies are due to medical costs. I think it's even higher now actually. These are people who can't get or have increased barriers in getting car loans, home loans, or student loans, putting them even further behind than they were in the first place. And providers, is that the same one?
It's okay. Something I've noticed about these two talking points is that they're very similar but nuanced in a different way.
Yeah.
That how it's good for employers that a healthier workforce is more productive, but also a key point to remember is how much employers really are kicking in for their workers right now. I think Eli said it's something like an average of $11,000 for a worker with a family of 4.
Yeah, now it's like 14.
And they also have to hire staff in order to argue with the insurance companies in their
You have to
human
have a benefits
resources
coordinator.
department.
Certainly.
You know, when you talk to those folks, they spend a lot of time trying to get people the services and the benefits that they're paying for.
Yeah, I mean, I think it's something like half of the work of HR departments is coordinating benefits. Now, you know, and a lot of that's just people who get hired, leave the job. That creates a whole lot of paperwork every time. This is, of course, if you're lucky enough to work at a company that has benefits. You know, and then you know, it's this enrolling, unenrolling, changing status. It's all it's a ton of work, and there'd still be some work for HR, obviously, but you know, the amount of money that employers spend is outrageous. I just wanted to say one thing here about the Yusuf Rabi bill. He senses there's a little bit of a danger here, a little bit of a trap. If you can see where this is going, it might, you know, turn out to be a giant windfall for corporations like, you know, Ford or Quicken, or you think of some of the biggest, you know, companies here that do provide benefits, where you're taking the out-of-pocket burden away from us.
You mean like the tax reform bill?
No. Well, I mean, that's the other argument, is that there's plenty of money now, and this is actually also linked to the Rabi bill. This is why they have to keep changing, because events keep changing. But basically, the first point, if you take this away, you are saving, you know, a company like Ford or a company like, let's say, Quicken, that doesn't have a unionized force, something, you know, on the order of an average of, you know, $6,000 per employee or $7,000 per employee per year. So you're
Although
saving
they
them.
will be taxed. So
Right, well, that's the thing, so that Rabi is building the legislation so that the taxes will replace most of that. So there's still gonna be some savings for like a Quicken or a or something like that, but it's not gonna be a windfall that's supported by taxpayers, even if the
And
tax.
the national programs also have that.
Right, so I know that's a very nuanced point, but when you get down the road to this, it might strike you as like, wait a second, we're removing all these taxes from these big corporations that can absolutely pay for it. They will pay for it. One of the other things too, though, what Margie mentioned with the tax reform bill, before, you know, it was really hard to talk about sources of revenue for a state single payer. Where are we going to get the money? And we still will need to change the Constitution to be able to do progressive taxation and remove the limit on revenue that we can take in as a state. We can do that. If we can do voters, not politicians, and promote the vote, we can do this in 2020. But there's also now all this money. The rich just got a hell of a lot richer in Michigan. So like corporations, wealthy people, you know, they repealed the estate tax, right? And so now we can impose our own estate tax in Michigan. So, you know, there's a lot of sources of income here that don't fall directly on average people, in part because it's the ironic result of what they're doing in Washington. Sorry for the tangent.
No, that's good.
And then my last quick point on employers, that's less wonky, but I feel it's still really important because it's one that was trotted out when the ACA got passed, which is, I'm not in this business to give my workers health care. I want to be a woodworker. I want to work on cars or whatever it is, you know. So employers would be free to focus on the business that they intended to start rather than having to pay their HR department to administer health care for their workers.
Yes.
Well, I don't know if you're the best one to answer this, but I'm surprised there's not a subset on, like, I like the CEO from the EpiPen, you know, how much he made last year, but it seems like, you know, in terms of the pharmaceutical industry and everything else, that Bernie did really well in Michigan going after the 1%, or, you know, we've done pretty well on 1% since then, and to have some sort of subset on that in terms of how they're just raking it in around the Oxy, you know, what's the name of the company that's just made, I mean, granted they've financed museums and everything else, right? But it just seems like 3 or 4 of those bullet points for talking points, or even in Michigan,
Yes.
two or three companies that have made tons of money, you know, having that, at least as DSA, I'd like to see that as part of our package of when we talk to people.
There's
Yeah,
a
that
visual
would be
slide,
great.
and
There's a slide.
Physicians for National Health Programs compiled, there's an image of like 6 to 8 CEOs and what they've been
Yeah,
making.
top health insurance companies, but we could also have one like about pharmaceutical companies too.
And medical device companies.
Yeah.
And the fact is now hospitals are buying physicians groups, nursing homes, all sorts of things, you know, that they are doing that, and then all the money goes out.
So anybody else? Right now. So switching to a single payer system would allow healthcare providers, doctors, nurses, dentists to focus on patient care again instead of trying to spending almost 40% of their time dealing with paperwork and challenging insurance company denials and trying to get reimbursed for certain services. So a lot of providers should be on board too. Eric mentioned the Physicians for a National Health Program, which is a nationwide organization that's been working on Medicare for All for a while as well. And use of a Medicare for All provided health chip card, which would contain medical records and immediate reimbursement to the provider, would mean that doctors and hospitals would no longer have to bill any insurance companies, and this would massively reduce administrative overhead costs for doctors and hospitals. And we believe Medicare for All would be the most efficient and least expensive way to deliver health care for everyone. The U.S. multi-payer healthcare system is inefficient. We spend far more than any other developed country on healthcare. In 2016, our country spent $3.2 trillion on healthcare expenditures, and the Medicare for All Act, like I said earlier, is estimated to cost $1.4 trillion. So we're already saving just in that way and cutting out all that overhead. And the U.S. has worse health outcomes than other developed nations with universal health care. So some people say the U.S. has the best health care system, but how can you say that when we have poor health outcomes? And this can be traced to lack of affordable access to preventative treatments. And as you can see, the average life expectancy for U.S. citizens living in is lower here than those living in countries with universal health care like Germany, the UK, Canada, France, Sweden, and Italy. And our infant mortality rate is also higher. We have more infant deaths per 1,000 live births than countries with universal health care like Canada, France, Germany, Australia, Italy, and Sweden. And we have over 2 times the infant mortality rate as Sweden, as you can see, and almost 2 times that of Italy. And our maternal mortality rate is shamefully high compared to Canada, France, UK, Germany, and Australia, over 5 times the rate of France and UK, Germany, Australia, so those 4 countries.
It's something where you really see the lack of preventative care.
And if I could just say
Right.
real quick, the way that I always frame this to people is every time a Canadian mother dies in childbirth, 5 American mothers are dying in childbirth.
And that's insane.
Yeah.
We also must acknowledge the racial and ethnic disparities we see in healthcare. We know Black and brown mothers account for a greater proportion of maternal death rates. I think there was a new piece in ProPublica that was saying that Black mothers die at 12 times the rate of white mothers in New York. So big problems there. And this is, I think, the last, the second to the last. A single payer system would be most efficient and least expensive. Ways to deliver health care for all. Only by enlarging to the largest possible pool can the risk and expenses be spread widely enough to eliminate cost sharing, those co-pays and deductibles. Having the largest possible pool would also allow for huge renegotiation of drug and equipment prices, and health insurance providers with record profits in the first quarter of this year, like even after the ACA, it hasn't really restricted these companies from making more and more profits every year. So Humana, Anthem, Cigna, and United Health we're making top profits.
And isn't one of those looking to buy out one of the other ones?
Yeah.
Oh, yeah.
Yeah.
Everybody's buying out everybody at this point.
Yeah.
Great sign. I mean, we might have a national healthcare system only because there's gonna be like 2 healthcare providers.
Right. And every other industrial country in the world has some form of universal health care, including many with some form of single payer except for the United States. So why don't we have it here? Probably the lobbying power of the insurance and pharmaceutical companies does not exist in other developed countries like it does here. Profits continue to rise in these industries while our premiums and deductibles continue to increase. And there's a lot of talk about it, but I don't see, like Debbie Stabenow was talking about the prices of pharmaceuticals, but she didn't really propose like a plan to stop this rise. She has to decrease Medicare eligibility to 55, but that really won't do anything to help our maternal mortality rate or the infant mortality rate or the rise that we see in these prices.
Well, I'm sure most of you know that we are the only country that allows pharmaceuticals to market their products on TV
advertise.
and all of those sorts of things. I mean, the amount that they spend on marketing their products is gigantic.
It's
And
bigger than
if
what they
we would
spend in
just pass
R&D.
legislation to say that they could no longer do that, that would go a long way to cutting their costs.
Right. And there's a myth out there that free market works best, but as everyone in here probably knows, that we don't see that trickle down effect here, and our premiums just keep going up while health coverage and industries make record profits. And here's that slide that I got from PNHP. Just health insurance company CEOs are making tens of millions of dollars a year, while the majority of Americans can't afford a $400 emergency now. And also, we see our prescription drug spending, like I said earlier, just keeps going
That's
up,
insane.
and there's no
I mean, I'm sorry.
end in sight. It is.
And the CEO of Blue Cross Blue Shield of Michigan just got like a huge bonus. What was it, 13 million,
Yeah,
30
I
million?
think so.
13 million, yeah, even though profits have gone, or premiums have gone up like an average of, is it 10 or 15%?
Yeah.
And they seem to be really taking the market over in Michigan.
Oh, they've had it for a while. They definitely are.
And, actually, this is
really
a just one point too, because I think it's something that came up too recently. It's not in the common challenges, but we should bring it up, which is a lot of people say, well, Blue Cross Blue Shield isn't evil; they're a nonprofit. I've seen this a lot.
Not anymore.
Well, maybe you could speak to exactly what they are, because there are, the idea of the Blue Crosses were that they would be nonprofits, so they have to have like charities on their board, or like Catholic priests or whatever on their board and stuff, and they don't have shareholders, so therefore supposedly that's like was like supposed to be like America's version of socialized medicine. But the reality is, of course, that you see that they're run exactly like for-profit companies in their advertising
And 3 years ago, they won the ability to become for-profit in Michigan. And as a part of that, they negotiated a sum of money that would go into a foundation to meet healthcare needs. But we got so much less than any other state. They've done that in a whole lot of other states. And they have huge foundations. But what we got was just a pittance of whatever we, because we didn't have the will at the state level, legislatively, or in the governor's office or whatever, to truly negotiate that the way other states did. So we have far less money coming out of that, but they are for-profit now in Michigan.
And they'll say that they had to do that, and I've heard them say and said on their behalf that they had to do that, otherwise they couldn't compete with the for-profits. which
That's
is of
right.
course how neoliberalism
And they have
works.
always been the elephant in the room in Michigan.
And being a nonprofit, they don't have a limit on how much they can pay their CEO, right? Or different bonuses.
Well, they didn't really have.
They should.
Yeah, absolutely. You know, we are so unregulated except in the Medicaid and Medicare and VA programs where the government has a heavier hand in being able to do that. CMS in negotiating with the other systems, insurance systems and pharmaceuticals has had little ability to bring them in.
I would say just one more thing. I mean, going along with the prescription drug thing is also tying. You could use this time to also the opioid epidemic that we have,
Yeah.
and that
That's
you know
right.
people are being given fentanyl or whatever at this obscene rate, and that if they had the proper care, they wouldn't have to be going through these. They wouldn't be suffering and having to go through this debilitating pain or whatever. You have the treatment right up front.
Right.
So
You're
I don't know if
treating the
that's
cause
something
of the
later.
pain.
Mhm.
Yeah.
Eric and Sarah, maybe for this next portion, we could ask people what they hear about not doing it and then make sure that we cover all of these things. But let's get it to be a little more interactive.
Oh,
You
yeah.
want to start? Yeah. Asking people?
Oh, yeah, well, I don't know if Sarah wanted, if this was the last slide. or
This
not,
is
but yeah,
done, yeah.
Okay, cool, great. Well, I'll just come to the front then with some notes. I'm gonna talk about some of the common challenges and the pushback that we hear from people, and then we'll see what you guys are hearing and what you have to say. So I'm just gonna keep around in the front real quick.
Thank you, Sarah.
Yeah.
Oh, thank you guys.
Thank you very much, Sarah. Just gonna put this in front of us since I'm not using the projector. Okay, great. So, we'll take us on a quick 15-20 minute whirlwind conversation about some of the pushback we're hearing, and I'll start with some of the topics that we've already heard, and you guys feel free to jump in. So one of the things we hear a lot, like we talk about with unions, people say, I like my plan. Well, the question is, what is it that you like about your plan? Do you like paying co-pays, premiums, deductibles, or is it that you like going to your healthcare provider, who you'll still be able to go see, and then if they're out of town, you'll get to go see someone else for a change, instead of having to wait for an in-network provider to come, who would have the time slot to be able to fit you in there. So what you find is that people don't necessarily like the bills and the baggage of a plan and the restrictions of having a network. It's that they might like their specific doctor who they've maybe been with for a number of years.
And Eric, there's one other thing that is under that is that a lot of people are getting surprise bills, that they are in the hospital and somebody out of their network treats them because they are there and they need that treatment, but then they get charged for that. So more and more I hear from people who are getting surprise bills.
Well, that's what happened to me. I had some back pain, and I went to just a local clinic, and they ran it. They said, oh, your card's good, or, you're fine. And then about 3 or 4 months later, I got a bill in the mail for $120.
Wow.
Well, I paid my copay, and I was asking them, well, what's the bill? Oh, we're not sure. I said, well, how do you not know? Well, we'll see what happens.
Well, to speak to that is, people will talk about receiving bills for treatments that their insurer will tell them, well, you don't have to pay that, we're paying that. Well, is that how you should treat all your bills? Just assume someone else is paying it and let it sit on your table? Or should you, it's just not, that's not a good way to take care of care.
As someone who currently has a plan that I like, my rebuttal to that would be, what if you lose your job and you lose your plan? And I recently had a condition caused partially by work-related stress where I couldn't walk and had trouble getting to work, so I was in fear of losing my job and losing the treatment that would get me back on my feet. So I don't think anyone, even if you have a nice plan right then, should take it for granted that it's going to stick around. And I don't think anyone should be fearful of losing their job because it would mean not having health care.
Certainly.
And even if you have, my husband worked for Ford Motor Company, we always had excellent care. I've had 4 cancers, and I'll never forget the first one that I had. I argued, and my physicians argued with my insurance company, who kept wanting, first they wanted a second opinion, then they wanted a third opinion, and then they weren't sure that they wanted to pay for it until my doctors and I just got on our high horse and said, we're doing it and you're paying for it, and then they did. But when you have things like that, the stress of just having it and then having to argue with what you thought was very good health care in order to get something treated as life-threatening as uterine ovarian cancer, you know, you just get the feeling that what they really wanted you to do was die, and then they wouldn't have to pay anything, you know, kind of thing. I mean, that's the way I felt, and that's what I said whenever I complained.
Yeah, people are not, I mean, this is not always the right thing to bring up depending what crowd you're talking to. But the reality is that health insurance doesn't make sense. I mean, when you come right down to it.
Yeah.
Auto insurance maybe, homeowners insurance, sure, because you're essentially pooling against something that's happens to a minority of the people in the pool, right? I mean, it's not predestined that every single car is gonna crash. Every single home is at some point going to burn down, right? Or almost all of us, unless we, you know, suddenly get killed or die all of a sudden, you know, at a young or while we're still in the prime of our lives and healthy, which is not most people. Most of us are going to need to go to the doctor. Most of us will need insurance. So the reality is, like, the reason Blue Cross Blue Shield can't operate as a true nonprofit is because there's no way to make it like as a business. You know what I mean? Like, it has to be done profitably. And once you get to that, you have to start doing things like what happened to Margie. Basically, they employ huge numbers of people whose job it is to try to stall, delay claims. They know somebody's sick. They know they might be terminally ill. They can see, they have, you know, actuarial sheets. They can see how much money they personally would be responsible for saving if they delayed treatment and then somebody died. So then they don't have to spend any money on their health care because they're dead. Now you're talking about funeral costs instead, right? And then they get bonuses that all adds up, and you can see quarterly how much money you save the company by delaying or stalling care or whatever. So, and that's how they make their profit margins. That's where the money comes from to pay 13 or 30 or 40 million dollars to CEOs to build these sparkling new, you know, headquarters, to have these, you know, impeccably produced commercials that are on every single commercial break, it seems like, on TV. They have to do that by denying care.
I urge everyone to read Wendell Potter. If they aren't familiar with Wendell Potter, he used to work for Aetna and is scathing about exactly what Eli is talking about.
It was his job. And he was one of the few people who quit because he couldn't live with himself. That was how he made a nice big salary.
Certainly, they make a lot of money by denying care. They like to call themselves healthcare providers, but they're healthcare deniers.
I mean, if you work at Jets Pizza, what kind of business model would you have if, you know, for every 10 customers who place an order, like, you know, 2 of them go in and they go to pick up their pizza and you say, I'm sorry, you come up with some loophole as to why, like, you take their money but you can't give them a pizza.
We don't think you really need this pizza right now.
Right. But you already paid,
actually need a
so.
which, not to get to that, but anyway, so that also gets to the pushback where we've said healthcare is a human right. People will say, well, I don't really think it's a human right. So first of all, it's outlined in the preamble of our Constitution to provide for the general welfare, and courts have affirmed that Congress can raise money to do that. In the Declaration of Independence, we talk about life, liberty, the pursuit of happiness. But then you just get down to the nuts and bolts of it. Even people who would push back on this, if they didn't have health care and you get to a catastrophic incident, you're going to take yourself to an emergency room and assume that someone's there to take care of you because you think that everyone has the right to care in the event of an emergency. And so we are already, even those who would push back, some of the strongest push back against it, have to recognize that they themselves act like care is a universal right, unless they would advocate for denying people in emergency rooms, which I guess some of them would.
Yes. And I'm not so sure that we weren't headed in that direction in the last couple of years.
Certainly, and there are a lot of nightmare stories sort of around that issue, but and that does push into the healthcare isn't a right, sort of gets into some more pushback we get where people say, I don't want to pay for someone else's healthcare. Well, we're already paying for 75 million people's healthcare through Medicaid and CHIP, the Child Health Insurance Program. Another 50 million through Medicaid, so you're at 125 million there, like 55 million for Medicare, I meant, sorry. And then so another 10 million for the VA, you're at 140 million Americans out of 350 million Americans that we're paying for. That's not including every public worker's healthcare, from legislators to firemen and public teachers. And then, just to get to the issue of the emergency rooms again, we spend about $50 billion, there's about $50 billion in annual unrecouped costs that taxpayers are picking up on that. If you don't want to pay for other people's health care, we're already paying for everyone else's roads, hopefully there's schools, potentially, supposedly our clean water, and certainly we're all paying for a socialized military, so I think that we could also invest in a socialized healthcare system.
And when they say they don't want to pay for people, through the emergency room, people may get in the hospital, but the kind of care that some people are getting, we have stories all the time about hospitals taking someone who doesn't have insurance, and for a long time, Medicaid, the same sort of thing is that, well, most people would stay in the hospital this many days to do it, but they pushed you out early. We even had people who were put on Coumadin when they went in, and you need Coumadin to be, your blood work to be followed. And what they did was they came into the hospital room and said, well, you're getting out at 3, and here's a list of places you can call who may be able to follow it. And almost all of the numbers on there were not good. That's the kind of care we were giving whenever we thought these people are not worthy.
Care.
Yeah, I used care,
And I guess to your point, a lot of people don't realize that I didn't realize until I spoke with Sarah, because she's a nurse. Insurance companies have their own internal lists of, they know to themselves how long it should take you to get better from a certain illness. And once you go beyond the 2 to 3 days or 2 to 3 weeks, they're just really doing their best to push you out of that bed to fill it up. Because like the hospitality industry of hospitals and then for-profit prisons, they fill their beds as fast as they can, and then when they try to get them, out to the next person. So,
and this also connects to the opioid too, because we talked to a lot of people who've had really awful experiences with substance addiction. We have a person that we know whose girlfriend died of alcoholism. She just, drank herself to death. When he finally was able to get her, it's hard enough to get people with substance abuse to go to rehab. Then you got to figure out how to pay for it. And insurance usually, in this case, her insurance paid for something like 4 days in detox. And I think most mental health professionals, substance abuse professionals would say minimum of 28 to really get healthy and get recovered from an addiction. So it didn't help her at all.
You go into the hospital and you say that you have an opioid problem. They'll give you a sheet of paper that's been through the copier so many times it's almost unreadable. And they'll give you directions on what to do. They tell you to stay warm, avoid drugs, avoid caffeine, avoid cigarettes. So they want you not only to be going through withdrawal from the opiate, they also want you going through caffeine withdrawal and nicotine withdrawal at the same time. But this is their idea of sending you to rehab. This piece of paper, this is what you do. And I know that from personal experience. So it's totally unrealistic and totally unhelpful, but that's the only rehab my insurance will pay for, is that sheet of paper.
Wow.
It's incredibly ridiculous. This idea that people don't deserve it, like the people perhaps on Medicaid or Medicare. Medicare, those are seniors by and large, or people who need
Disabled.
like really cash or disabled. Yeah, and so they've spent their lives, most of the time, spent their whole lives paying into the system. When it comes to Medicaid, 60% of people on Medicaid work currently, and 80% of them live in a household where someone's working. So there's only 4.8 million people who don't work and receive Medicaid. It sounds like a lot to someone, general American doesn't earn $30,000 a year, half of the workers, but so to pay for $638 million might sound like a lot of our $4.2 trillion budget, but for someone in Michigan who earns $50,000 a year, that's $2 of your annual income tax that you're paying to support those who receive Medicaid and don't work. It's 0.015% of our federal budget.
And we should, the work requirement that they're going to be voting on in Michigan very, very soon. How many of you saw what Minnesota just found out? Anybody read that article? Minnesota did a study to see how much it would cost them to implement the work requirement. They found out they would have to put in 300 new workers and that they would spend more money on administration than they were gonna save on the work
Well,
requirements.
it's been the same thing they've been doing with some of the states that have been doing the drug testing for
Sure, exactly the same.
unemployment and such, and they found
Exactly
that
the same.
they saved $5,000 and they spent $50,000 or $60,000.
The reality is most of the people who are supposedly not working on Medicaid are people who are disabled, you know,
That's
and
right.
aren't necessarily like in treatment, but they have untreated mental illness or, you know, just simply untreated physical ailments, you know, or substance addiction. They're not gonna start working just because there's a requirement. It's vanishingly small. It's tiny. This is like the voter fraud.
And Eric, I'm gonna bring up that there is also some racial bias in this Medicaid kind of thing.
Absolutely.
I wanna tell you one story. The head of the Kellogg Foundation was a black woman, very articulate and everything else, and she talks about when she had her first child and she went into the hospital, they put her in the hall. They assumed because she was black that she was on Medicaid and they weren't going to give her a room. You know, that she was just in the hallway and that sort of thing. And when her doctor came in, he blew the roof. And they told the doctor, well, we thought she was on Medicaid. So they were not going to give her the same kind of care that they would give someone who had a different insurance.
And I mean, this has parallels with sort of the immigrants' rights issues of
That's
like,
right.
are we gonna be checking people's IDs before we
That's
take them
right.
to an emergency room? Or are we gonna make someone prove they have eligibility when they're in the hospital about to give birth? Or perhaps, you know, dying of a heart attack?
Well,
So-
the first thing they ask for in the emergency room is what type of insurance you have before the doctor will even see you most of the time. So of
That's
course
the
that
first part of the
influences the
Hippocratic
type
Oath,
of care. Yeah.
Eric, one other argument I hear a lot is, maybe it's because I come from a Catholic family, so it's all about your personal morality is, you know, well, why should I pay for a smoker? Why should I pay for someone who drank too much? Why should I pay for someone who had an addiction and now has all these resulting physical problems, you know? Why should I take on the burden of, you know, your bad, what they view as bad moral choices?
Because that's what Christ would do?
Yeah, well, it's far too basic. I think the best is, well, but I bear the risk, the fact that you're a downhill skier. I bear the risk that you sometimes
Text and drive.
Yeah, that you text and drive. I bear the risk that you own a sports car that won't crumble on the smallest of impacts. I mean, people don't realize that, well, you know what, you're a risk too. Unless you're literally sitting home on your couch, in which case you're a risk for heart disease.
Right.
We all bear the risks of each other's behavior. So.
And to get to what Roseanne said, I mean, the issue of public health being an overarching issue where you think like, oh, I got my health. It's not like $1 in your pocket where it's something that you can just share with someone. I mean, we're all part of the same ecosystem, the same, I mean, we're sharing our microbiomes and just in the air of this room as we exhale. So unless you're just gonna sequester yourself off from society in some sort of medical safe room,
Well, think
you're
of all
gonna be
the
exposing
people-
yourself to sick people.
People getting their water shut off.
Sorry.
And folks are like, well, why?
Pay your
Okay,
bill.
they don't pay their bill, I don't care if their water's shut off. Okay, those folks with their water shut off who are now more at risk for hepatitis, go to work at their sub-minimum wage job at Burger King, and you go to Burger King, and they were just touching all your
Sure,
food.
absolutely. As a
So-
restaurant worker, I couldn't agree.
People do not see the public health implications.
Yeah, everything's connected.
Yeah.
Absolutely. So we talked about the eligibility. Some people will say, you know, like it was such a pain trying to get on Medicaid or trying to get the VA to recognize that I actually was a vet and did incur this injury. All of those eligibility requirements are going to be gone. We're all going to be able to use the same health system. You're not going to have to we talked about the waste in money, but also the waste in time of just running everyone through the gamut of finding out what network you're in, if you're in a network at all, and if you're not slamming the door on their face.
Yeah, I mean, there's the applying to be on Medicaid is like a full-time job in itself. You know, and again, this is the thing to emphasize to people is this is automatic enrollment. You're born, you're in it, you get a card.
That's it. If you could just speak real quick, Eli, because I know that this seems really relevant here. When we talked about the card chips, when you were in Germany, did you have one of those
Yeah.
when you lived there?
Yeah, I lived in Germany for 4 years. I had a kid born there. Again, Germany isn't a complete single-payer universal healthcare system, but it's very close in that it has an enormous public option, actually two sort of public options, and then it has some private plans that you can opt for, or that employers sometimes will opt for to increase their employees' chances of coming. But it's not like you aren't taken care of with everything you need. And so we just had a card. They had this is 15 years ago. They had chip technology in the card, and you just go to any doctor you want. We didn't know who to go to. We just went to the pediatrician that was right around the corner from our house because it was the closest, and we didn't have a car. And then when it was time to give birth, and then wife, we picked this like really hippy dippy midwife clinic that was like all natural, and it was pretty intense. But in the end, we could have gone anywhere we wanted. We went there, and it cost us like 30 euros total, right? And the average birth costs something like, where everything goes smoothly, I think it's like 20,000, 10, 20,000, something like that. Or more, and again, you just get there, and we qualified because if she's it was an EU citizen, so, but again, just a card, you take it anywhere, it's got all your information, and that's all you need to do.
And that brings up the issue that people push back and say, well, the free market decide the cost and the access to healthcare, but when doctors are in network, they're really only competing with other doctors in their network for other patients in the network. They're not competing with someone down the street who treats patients from another network. And so if we're really going to have actual competition among physicians, healthcare providers, and for people to be able to so to speak vote with their feet on what type of care they want to get, you should be able to go to any doctor.
Free markets are good for wants, not needs. The way we organized our democracy was, things like schools, and we didn't do healthcare, unfortunately, but schools and roads and infrastructure and that sort of thing, it all seemed correct that we pool our money and send it back out and take care of things, but we didn't do it for that. So the free market was not meant to meet everyone's needs. A free market works whenever you can compare. You don't go out and compare and shop. I didn't go on the internet to see how much a Whipple would cost when I had pancreatic cancer. It wasn't something I would even think of doing. Now, if I needed an operation, I needed it now, and you go where your doctor tells you to go. That shopping for healthcare is the big thing now. Compare. There's all of these sites. And that's okay if it's something that you can look at and do in the long range. But when you're under stress and you need it now, there's no shopping.
When you're in the middle of cardiac arrest.
Yeah, and even, the vehicle will take you, the EMS will take you to the closest hospital, not the one you want to go to.
Yeah, and then there's the problem, people keep saying Medicare for all. But Medicare is expensive. I just recently got onto it, and first month they took $150 out of my Social Security. I have to pay 10% of my drugs, I have to pay co-pays, I have to pay all of this, and this is Medicare that I've been paying into since I was 15 years old. And I also am qualified to get the assistance. So supposedly Medicaid is going to pick up the cost of my Part B, and this, that, and the other thing, but they decided that I had applied too late, although they told me when I went earlier that it was too early. It's going to be like 4 months before I'll even be able to go back to the doctor because of the costs.
That is something that people bring up, which is Medicare. You have to get Medicare Advantage plans. It only covers like 80% of your costs. You're still getting these premiums or co-pays.
Improved Medicaid.
It's
Right,
improved
it's
Medicare
expanded
for through the HR 676, the House bill it's called expanded and improved Medicare for all.
And the Sanders bill is the same.
Yeah, and the real goal is, a national health insurance program, a single payer system, making sure everyone can go to a doctor when they want. But Medicare, expanded and improved Medicare for all is a vehicle for that. And so it would actually, Medicare would get better because people would have 100% coverage without any of those costs. And you would have the whole pool of young, healthy people paying into it the way that it's intended to be, so that you have the largest possible negotiating pool is the nation, or if not the world, or that, that's some real future thinking.
And also, just real quickly, the Robbie bill, the way it would work at the state level, you'll hear a lot of people say, well, we can't cover everybody in the state, that's too expensive. We don't need to, because basically that bill would be the supplemental insurance for Tina, for example. You wouldn't need to wait for Medicaid. Like, MyCare would just fill that in. And for a lot of veterans too, you don't get full coverage. It kind of depends like what your combat experience actually was, as Sarah could say. So this would fill in for the rest of what you don't get at the VA, right? So it doesn't actually have to cover everybody in the state. It covers the people who aren't on Medicare and Medicaid and VA and CHIP, and then it fills
the
in.
federal money with
Right.
state money.
I don't want to miss your question or comment there.
Oh, yeah, no, I had a question. I think it's a largely perception, I guess a lot of these arguments are, but one thing that I always come across, I've always been kind of dumbfounded on when people say, Canadians, it's like the Canadian style healthcare, they hate their healthcare. And there are Canadians that come here to get healthcare. I was wondering if you could speak to that point.
Absolutely. So our current wait times are sort of in the middle of advanced nations. What Canadians have a wait time for is elective procedures, whereas they still push people through for urgent care. And they don't have significant, they might even have shorter urgent care times, or it's just not significantly longer than ours.
Yeah, we have wait times now.
Yeah, currently,
When you
how
get
long
to
are
see
you
a
waiting if you
specialist?
don't have health insurance? You're not really waiting, you're just not going. Which includes, it gets to the topic of rationing care, which is the idea that Eli said he has health insurance and he still doesn't go unless it's an absolute emergency, just for the sake of the fact that they're trying to keep their costs within a reasonable amount, so.
And we ration care in this country for years and years, but just not giving care to people.
So I think-
that is a form of rationing, is not covering people.
I think also it's largely a myth.
Yeah.
All
Yeah,
these
it is.
Canadians are
Ask them for
flooding the
specific
United States
Yeah.
for their health care. I grew up in Buffalo, New York, which is a huge healthcare hub right now, and obviously adjacent to the Canadian border.
We're in
And-
Detroit.
Yeah, I mean,
They're right there.
part of what people don't seem to realize is, one, they're coming here for elective situations, and two, a lot of border city hospitals are part of or have agreements with Canadians' national healthcare
That's
system.
right.
So if you have a heart attack in Windsor, or a really, really bad situation in Windsor, rather than fly you to London or even perhaps Toronto, they bring you to the DMC.
That's a good point.
And I know it's true in Buffalo as well. A lot of Canadians come to America in emergent healthcare systems simply because it's really the closest center. And they have an agreement with the Canadian government that they'll treat these people at the apothecary of the national health system in Canada. So it's really kind of BS that there's this flood of people coming over because they'll die under the Canadian healthcare system. It's absolute bullshit.
And the
it just
polling in
bugs me.
Canada is clear that people are strongly
Yeah.
supportive of it.
Yeah, if everybody loved our healthcare system, why aren't they changing to it? It doesn't seem to happen. In fact, you see massive political unrest when someone tries to undo a national healthcare system like in Britain or Canada.
I was going to say, in Great Britain, you've had, Labour and the Tories trying to gut the NHS for decades, and they still weren't able to do it because people said, no, we like this.
Even Tory voters in Britain will see the NHS as something definingly British, and they will not.
Even Thatcher couldn't get rid of it.
So, and I won't say I have friends who do this, but let's just say I've heard about people who have friends who go over to Canada to buy pharmaceuticals.
Absolutely.
My wife does that.
Oh, hell yeah. Oh, okay, well, you'll say you know something.
Yeah, my wife does that
I won't
because
say
she's on a medication that
Yeah.
without insurance would cost us $1,000 a month. With insurance, it costs us $600 a month. Through this Canadian pharmacy she uses, it costs us $300 a month.
And it used to, I'm only 30, but when I was growing up, I remember it was a political stunt where lawmakers used to lead bus tours across the border to Mexico or Canada. And I've heard Debbie Stabenow brag about taking people across the border to get cheaper medicine in Canada. So if we're going to talk about who's going in which direction to get what care, we certainly have to mention drug prices.
I once had a couple at one of the places that I talked who moved to England because the cancer medications that they needed were so expensive that they just sold their house and moved to England.
Yeah, we have a guy we organize with whose father had AIDS and moved to England because of that. We're close to taking a break. One thing I just wanted to point out is that the no, I'm losing my point. Maybe we should just take a break. If I think about it, we'll bring it
If
up.
I could just say real quick, one of the things I really want to bring up is when people say, I agree, I love it, of course we need single payer, but it's just not possible. Well, how is it, if it's so impossible, how is it that Nepal and Botswana have it and America doesn't? Those are some of the poorest countries in the world. When we rolled out Medicare at 65, they had something like, in 1965 rather, they had something like 99% enrollment after a year and with index cards. You know, you would think that with the glory of the internet and our interconnected social relationships, we could all figure out how to sign each other up for this if need be. And then I think what people mean is that it's politically, they feel it's politically infeasible given our current climate. But to a certain extent, that's what this campaign is about, is shifting the Overton window. I mean, when I talk to people, it's not, do you have a healthcare horror story? It's generally, what is your healthcare horror story? My coworker the other day said, well, I don't really have one. It involves my parents. They kicked him off their health insurance, Blue Cross Blue Shield did, because he wasn't going to school, and they tripled their premiums.
Yeah.
It's like, yeah, that's a horror story. He just didn't really recognize that he was entwined in that way. So,
And government of, by, and for the people. If we aren't going to do by the people, then this is not a democracy. That we have to believe that the people's will can take precedent if we join together and express our will. But the other thing I want to say is that we have to remember that democracy is hard work, that even if we get this, keeping it, we need to know that it will be an ongoing struggle to be able to keep it. And you can't let down your guard and think that, well, now we're here. We did that in 2010, obviously, when we got the ACA. And look how quickly it has been undermined when a different person comes in to the leadership. It is just incredible to me about the numbers of things that have been done. And certainly the ACA was not perfect and needed to be improved in moving to Medicare for all. But what we had got dismantled very quickly. And we can't forget that it's really important to keep your eye on the ball.
Yeah. I talked to Alyssa Stockin, who is the Democrat. She's one of the Democratic candidates for Michigan 8th representative. She's like, I will not sign up for single payer. We have to go through public option first because there's a lot of, well, what she really meant to say was there's a lot of Republican voters who are scared of socialized medicine. And because she's basically running as a Republican with a D next to her name, she was worried what they were thinking. But she said, we need to pass public option first. But I think they're not they're just going to cut that right out.
Yeah.
They're just going to.
Sure. And I think that, what we have to say to people is that, why isn't it the time?
Yeah.
I really think we need to push for what we need, and that is a healthcare system that covers everyone. And when anybody says that we have to do that, I argued that with Peter's staff and Stabenow's staff, several times recently about the time for the public option was 2010. You didn't do it.
Yeah.
Now, we have come a long way, we've learned a lot, and I think you need to get out and listen to people because people want a healthcare system that works for everyone. And a public option is never going to do it.
And real quick, I feel it's worth mentioning that these private insurers have huge war chests for things like advertising and for lobbying, and they're more than willing to take a loss on profits to undercut a public option to make their plan seem more attractive to people until we do get the public option, and then we're just right back where we started.
Yeah, because they can, moving to 80-20 for their profits, the 20% profits,
Amen.
if you take NRA money, we're not gonna vote for you. We may have to say, if you're gonna take insurance company money, we're not gonna vote for you.
We've done that. I've been arrested 6 times
Mhm.
doing that. And it doesn't seem to penetrate.
But now we have a model out there that seems to be
Yes.
catching fire, so that if it could catch fire. Sorry.
All right, no, that's great. Everyone's input was really helpful today, and we're gonna take a quick 10, 15-minute break, I believe, here,
10
and then Laura's gonna lead us in some direct canvassing training.